So next up, we've got Dr. Bride. So Dr. Bride is a consultant haematologist at Oxford University and then associate professor at the University of Oxford. She is a rare inherited anemia lead on the National Haemoglobinopathy panel, and Dr. Roy's main interests are haemoglobinopathies and rare inherited anemia, in particular the genetic investigation of inherited anemias, including whole genome sequencing. She's dedicated to using patients' views to guide how research is conducted in haematology and coordinating best practice care in red cell disorders at European level. Thank you.
Thank you very much. So I'm going to talk about CDA and DBA. CDA stands for congenital dyserythropoietic anemia, and DBA stands for diamond blackfan anemia. And I suspect that very many of you, it doesn't matter whether you're a medical student or a consultant hematologist, very many of you, when you get confronted with these conditions, you look like this man in front of a maze. And really what I want to do today is demystify it. And if there's nothing else that people take away from it, is that it's not as bad as it seems, and that it is possible to understand it, and that it's possible to really do the best for these patients. And I've chosen this image, CDA and DBA, as a sort of yin yang and the hot and the cold, and I'll sort of explain why. The first thing is that they are part of a whole, so they're both ultra rare disorders, they're both inherited. They may or may not be transfusion dependent, and that's true for both of them, and they're both associated with iron overload. So in a way, they're very similar. And in another way, they're quite different. So the hot side, the CDA, the bone marrow is really full, whereas on the cold side, the DBA, the bone marrow is really empty. CDA is recessive, and I'll come on to that. It's not always true, but mostly it's recessive, and DBA is dominant in terms of the inheritance pattern. In DBA, even carriers can be affected in some way. So I'm going to talk about that. Whereas in CDA, the carriers are healthy. Treatments on the DBA side, we've got steroids, transfusions, and bone marrow transplant. And on CDA side, we've got usually nothing, sometimes transfusions, sometimes interferon. And then DBA carries a risk of cancer, and CDA doesn't carry a risk of cancer. And I'm going to start with this idea about the bone marrow being full or empty. What do I mean by that? This is actually pictures from a normal individual, the more empty side of the bone marrow. And on the right is actually the bone marrow of somebody with thalassaemia. But thalassaemia and CDA are very similar because they both have ineffective erythropoiesis. So you can see that in a normal bone marrow, you only have a little bit in the bone, you only have a little bit of marrow that's working as an adult. And in DBA, you still have a little bit of bone marrow that's working as an adult, but there's no erythroid, there's no red blood cells developing at all. Whereas in CDA, the bone marrow is really, really full, and it's full of developing red blood cells. Unfortunately, they don't make it out of the bone marrow as mature red cells, but that's one of the main differences. And so if we look at what's happening in terms of red blood cell development, on the hematopoietic stem cells, and once they've decided to go down the erythroid lineage, they become more and more mature, they become pinker as they start to make hemoglobin. Oh dear. Well, hopefully you've all guessed what I was trying to say by looking at the bone marrows, but I'm just going to carry on. So I'm going to take a step back and look at genetic testing. And this is important because that's been really revamped recently by NHS England. So we now have these 7 GLHs, genomic laboratory hubs. And each of, out of those 7, there's 4 that provide genetic services for the whole of England. And I've circled them. So we've got Northwest, Northeast and Yorkshire, South and Central, and the Southeast. And in fact, when you look at the regions that they serve, so if you're here in the Northwest, you're actually serving quite a large proportion of patients in England, both in the Northwest and in the East. And the way that these tests are requested is through a national genomic test directory. So this sets out all the different conditions that you can test for free in the NHS, because this is all commissioned by NHS England. And one of these is rare anemias. And then if you look at the rare anemia page, you can see when can you test it? So you can actually test them either at presentation or anywhere at any time along the pathway. But the thing is, you've got to exclude acquired causes first. And this can be requested by both clinical genetics and hematology. And this is the panel. So all of the panels by NHS England are called R. I have no idea why. Our panel is called R92. And it's got about 100 genes. And here you can see all the different conditions that are covered. So we've got a few bone marrow failure genes. We've got CDA and DBA. We've got red cell enzyme disorders, red cell membrane disorders. This big piece of pie here is inherited B12 and folate deficiency. I have never seen a patient with any of these, but there's a lot of genes involved. We've got a few iron genes, methemoglobin genes, the haemoglobinopathy genes, and the sideroblastic anemia genes. And so today I'm just talking about CDA and DBA. And you might wonder, well, why have I chosen those two? Is it because they're the most common rare anemias? And in fact, this is the very fresh data that hasn't even been published yet from the National Haemoglobinopathy Registry. Nandini's laughing at me because I haven't actually sent in my chapter yet, but clearly I'm working on it. So you can see that these are in the National Haemoglobinopathy Registry, there's all the registered patients, okay? And you can see actually most patients with rare anemias are unexplained. So that's really important and interesting, and we need to think about why are they unexplained. Diamond blackthorn anemia is the second highest category, but CDA is not that high. So we've got more people with enzyme disorders, unstable hemoglobins, membrane disorders, and sideroblastic anemias. But I'm talking today about CDA and DBA. So CDA, congenital dyserythropoietic anemia. What does it mean? Congenital just means you're born with it. Dyserythropoietic, all it means is that the shapes are abnormal. It doesn't say anything else about the pathophysiology or anything like that. It just means they don't look right. And anemia is obviously too few red cells. And I've already shown you this slide. But if I put the same picture here along the side here, you can see we've got our hematopoietic stem cells and our red cells here. But I've put it on the side, and you can see that whereas on the previous slide, it looks like you start off with one hematopoietic stem cell and you end up with one red cell. In fact, those numbers expand. So you start off with very few hematopoietic stem cells, but the more they mature, the more they divide. And so you have this huge amount of proliferation. And then you've got, once they've all proliferated, you've just got maturation, get rid of the nucleus and come out into the bloodstream. So this is what the normal bone marrow does. And then in thalassaemia and in the CDAs and actually in MDS, all this erythropoietic, ineffective erythropoiesis, you look what you have a ballooning of these precursors. So huge number of these intermediate precursors that are trying to make red cells. And then something goes wrong and they all die. And then very few red cells come out at the other end. And what do they die of? Well, it really depends on the molecular basis of the condition. So in CDA, I've put three types of CDA, CDA1, 2, and 3. CDA1 is abnormalities in histone assembly, which I'm not going to explain in detail. CDA2 is abnormalities in vesicle trafficking. I'm not going to explain in detail. And CDA3 is abnormalities in cytokinesis, and I'm not going to explain in detail. But all of them end up that the red cells are not maturing properly, and that triggers this apoptosis so that the cells die because they know they can't make more red cells. And because you've got so few red cells coming out the other end, you have anemia. The kidneys sense that, they ramp up the erythropoietin because they're trying to compensate. So you have this constant drive to make more red cells. And that's why you have this very full marrow in the bones, but also in the skull. And this is the typical hair on end that we usually describe with thalassaemia, but this is actually somebody with CDA type 3. And then you can have ineffective erythropoiesis. So this person, if you didn't know anything about them and you saw this chest x-ray, you would think they've got metastatic lung cancer or something like that. But actually, these are all masses of bone marrow growing in the chest. So how rare are CDAs? We really don't know. There's very old data back from 2010 where you can see the top is supposed to be CDA1 and the bottom is supposed to be CDA2, and it's supposed to show you the number of patients that have been reported in each country with these conditions. And so it looks like there's a handful of patients in each country and that it's extremely rare. Now, what do we define as a rare disease? It means somebody that if it's less than 1 in 2,000 individuals, and we probably all know from Rare Disease Day that 1 in 17 individuals in the UK is living with some sort of rare disease, which is 3.5 million affected individuals. But we estimate CDA1 to be about 1 in 100 to 200,000, which I've tried to find an estimate of what do we have 100 or 200,000 of, and it tends to be hair. So I won't say for everybody. It's about one hair from a full head of hair. So we would expect to have about 400 people with CDA1. And I've just shown you that data, which I said we've got about 10 to 15. And on this slide, I've put 400 dots. And in yellow, I've put the number that I think I know of CDA1 patients. Okay, so I can't tell you all 60 names, but I think I'm aware of about 60 CDA1 patients in the country, even though there's only 10 to 15 on the registry. So the question is, where are all these other purple dots? Where are all these other patients? Are they all hiding in that big bar of unexplained anemias? Have they died because this condition was so severe that actually they never, it was an in utero death? Are they walking around with very mild CDA1 and actually they don't know they've got it and somebody's just diagnosed them with something else? Or they may be having transfusions for an unexplained anemia. So I'm going to give you a little bit more detail now about these different types of CDAs. And these are some pictures from bone marrows. So CDA1 tends to have this intranuclear bridging, but it's not specific. You do see that in other conditions. CDA2 tends to have lots of binuclear erythroblasts, and CDA3, I don't think anybody would miss CDA3. If anybody saw a bone marrow and saw a cell with, it has up to 12 nuclei, you would sort of seek help and say there's something really wrong. And the one I'm most not aware of, but I know most about is CDA1, which is autosomal recessive. It can present from high drops, and I've sort of know about a patient who was transfusion dependent from being in utero. But also we were diagnosing people in late adolescence or adulthood who've always known there was something not quite right, but they never knew what it was. It's a macrocytic anemia and the retic count is low. They can require blood transfusions, and they're very similar to what Nandini was describing about the non-transfusion dependent thalassemias, okay? They've got a big spleen, they iron overload, etc. We really should not take these spleens out because it doesn't help, and quite often it makes things worse. And they develop this non-transfusion iron overload, which, as Nandini said, is because of suppressed hepcidin, and they have this uncontrolled absorption of iron from the gut. 20% of them have what they call acral dysostosis, which basically I just call them funny toes. And I've been caught out once where I didn't take off a patient's socks when I examined her, and she's the one that said, "By the way, I have funny toes," and I thought, "Oh my goodness, I should have checked." And it tends to be really extremities. It doesn't tend to be the hands so much. Sometimes the thumb is a bit abnormal, but it really tends to be the toes. And the main thing about CDA1, the way you know it's CDA1 is if you see this thing called Swiss cheese heterochromatin. So if we do electron microscopy of bone marrow, we see that the nucleus has got little holes where the DNA is, the chromatin, okay? And to show you how it looks, a normal erythroblast is here and the CDA1 erythroblast is here. So you can see that the dark bit is even darker, it's black. Instead of having this fuzzy outline, it's smooth outline. And instead of being filled in, it's got these holes. And this particular picture wasn't taken from bone marrow, it was taken from cells we grew in the lab. So we can take peripheral blood from a patient, it has to be 30 mils, so it's a lot of blood. And we can grow it in the lab and look at what we get exactly the same things as we get in a bone marrow. And we can do electron microscopy on these cells, which means we don't have to do bone marrows on these patients. And what does this mean? What is this heterochromatin? It's all about the way that DNA is wrapped around nucleosomes and packaged in the cell. So the two genes that are abnormal in CDA1 are called codonin and then this funny name, C15 or 41. And the top one is the one that is, there's the most mutations. You see all of these black squares are known mutations, and the bottom one has got very fewer mutations. And they're the two genes that if you've got mutations in them, you get CDA1. And in terms of treatment, so first of all, a lot of people don't need treatment. They just need managing in terms of iron chelation, managing through pregnancy. Maybe they might need transfusions through pregnancy. And then some people are really severely affected and are transfusion dependent, but a lot of people respond to interferon. And for me, this is one of the most interesting stories about serendipity in medicine. The way we know now that interferon works, and we have no idea how it works, is that there was a French lady who was 28 who had CDA1 and was on monthly blood transfusions. And as you'll have all heard about the contaminated blood inquiry in the UK, the same thing happened in France, but maybe 20 years ago, we did our inquiry in France. And so this lady had been given contaminated blood during the 80s. She got hepatitis C. So she was then treated with interferon to clear the hepatitis C. And that's a 6-month treatment. And over the course of the 6 months when she was given interferon, she became transfusion independent. Now, obviously, they didn't know that interferon was a treatment for CDA. So when she cleared her hep C, they stopped the interferon, and lo and behold, she started needing transfusions again. So that was our first indication that CDA1 works. And we can show that in patients. So she had lots of bone marrows before and after interferon, and they showed that all these abnormalities resolved. And actually, we do it in the lab now. We grow CDA1 cells, we put interferon, and the defect goes away. But it doesn't cure it; it just treats it. So we have no idea how it works. CDA2 is also recessive. It's got mutations in a protein that's involved in trafficking proteins from the Golgi apparatus onto the red blood cell membrane. And it can mimic a hereditary spherocytosis because in putting proteins on the red cell membrane, if that doesn't work properly, some of the proteins that should be there aren't there, and you end up with hemolysis, and you end up with something that looks like hereditary spherocytosis. Their spleens can become absolutely massive, and they can take up most of the abdomen. And CDA2 is the only one where we would consider a splenectomy. And in fact, a patient in Basingstoke had one. He went from being transfusion dependent to transfusion independent, having a splenectomy. And then CDA3 is an autosomal dominant. So I said CDA is usually recessive, and that's because by the majority of these very rare disorders are CDA1 and 2, which are recessive. CDA3 is dominant. It's a mutation in a gene called KIF23 that is involved in how, once the DNA has been copied and you've made your 2 nuclei, you need to separate your cell into 2 cells, and that's the bit that doesn't work. That's why you end up with these erythroblasts that have 12 nuclei, because they keep copying the DNA and then they can't separate the cell. Only 3 families are known worldwide, and it's usually a fairly mild anemia. And then I've seen my first case of CDA4 just this month. So this is a Moldovan couple that is pregnant, and they were coming for scans, and they realized that the baby looked very small, and they did middle cerebral artery, the umbilical artery velocities, because it looked like it was developing hydrops. And so it's a very anemic baby. So they started doing intrauterine transfusions for this baby. And they gave us some samples from the baby, and this baby has a mutation in a gene called KLF1. And KLF1 is a transcription factor, which means it's involved in turning on genes that are on in developing erythroblasts. So the commonest one that most people know about is beta globin, but actually will be involved in turning on lots of different red cell genes. And this baby has a KLF1 mutation, and it's de novo, meaning that neither the mum nor the dad have the mutation. And that means that either one of 2 things might have happened. Either the mum or the dad, the dad's gametes will have developed a mutation. So during spermatogenesis or oogenesis, the mutation will have arisen, and that's the one that led to the baby. Or actually the mutation could have arisen in the embryo itself very early on. So that's how the baby ends up with the mutation, but not the parents. And essentially, it's extremely rare, CDA type 4, but what we are telling the family is that chances are this is just going to be a transfusion dependent baby, like any kind of thalassemia. So I've spoken about interferon for CDA1, and we don't have a specific treatment for any of the other CDAs, but basically whatever treatment you want to give the patient, it has to be a partnership between the patients, the doctors, the patient organizations, the nurses, and then ideally even psychologists, etc. And so a lot of looking after CDA patients is about making sure that they know and understand their options, that they know about healthy diets and needing to take folic acid, that they may need transfusions. Some of them, it will be lifelong, and some of them will be just to get through, for example, pregnancy. We're really not advocating any splenectomies. And then we also need to prevent osteoporosis, which is a real danger in a lot of these inherited anemias. And so we need to give really good vitamin D levels. And this is one of my CDA1 patients. She is obviously given consent to have her photo here. And you can see she basically has that thalassemic facies that we're used to seeing with undertransfused thalassemias. And essentially, when she was growing, she should have been given transfusions, or she should have been given interferon as she was growing, because unfortunately she's developed those changes in her bones. When she came to me, she had cardiac and iron overload, and this is her ferritin, and she'd been getting vivisections for iron chelation, basically. And so when she came, but she'd been very poorly compliant. So we agreed that she would take interferon to push her hemoglobin up so that we then could do vivisection, and she would take Xjade. Now, obviously, we were moving to the film-coated Xjade, so it was better, it was more easy to tolerate. But between working together as a partnership and agreeing together how we're going to do it, this is what happened to her iron. It took a couple of years to get down, but she cleared her iron completely from her heart and from her liver. And in fact, she became so iron deficient that I had to give her IV iron. It just blew her mind that she needed to get IV iron. But this is something that I sent her, and I always think it's so helpful to print out the graphs for the patients, because the ferritin doesn't mean anything to them. But when you see the line coming down, you feel like we're getting somewhere. And so I would print it and give it to her so that she could see the progress, and she's doing really well. And then just more generally, when we're looking after people with rare disorders, chronic conditions, we've got to think about mental health. The mental health issues come from having a chronic illness, having a rare disease, and also the reproductive implications that it has for a lot of patients. I'm going to move on to DBA. So this is my summary about CDA. The bone marrow is full, mostly recessive. The carriers are healthy. We can treat with interferon transfusions or nothing, and there's no risk of cancer. Before I move on to DBA, does anyone have a CDA question?
Can you have a CDA diagnosis made on a bone marrow, but nothing else on genetics?
I think that's really, really difficult because it's non-specific finding. If you have a CDA, so in fact, when we did sort of genetics of all of our patients, we sort of did about a cohort of about 70 patients. What we found is that CDA is overdiagnosed, and that the commonest cause of what looks like CDA is actually PK deficiency. So if you've got a very active hemolysis, then the red cells don't have time to mature properly and they look dyserythropoietic. So a lot of these CDAs by bone marrow turn out to have something else, usually hemolysis, like a hemolytic anemia.
And we do have one question.
Yeah.
We have one question over here.
Yeah.
We'll go to online.
I you talked about intervention.
Yeah.
CDA.
Yes.
Is that form of treatment?
Yes. So in fact, so this baby that with the CDA4, and then another baby in Southampton had a intrauterine transfusion, and that's we made the diagnosis of CDA1 before birth. So I went to see this one, and it was my first time seeing one, and it was absolutely amazing. I mean, if you ever have the opportunity, the skill of those fetal medicine doctors who just put the needle. And the other thing is you have to wait for the baby to cooperate. So they sort of do a lot of tapping of the abdomen so the baby turns around and doesn't go too close to the cord. And then I hadn't realized this, but they inject atracurium. So the baby's moving around, suddenly it just stops moving completely. And then that's when they do their it's really scary. They put the needle, and of course the mother's watching the whole thing. They put the needle in, and then we're used to seeing a transfusion as a big bag. They've got these tiny little needles. A mil of blood is going in, another mil of blood is going in. It's amazing. But yeah, and that's the way to get them through the pregnancy. Yeah, and the CDA1 baby, so he was transfusion dependent. We wouldn't use interferon in the first year of life. So he was transfusion dependent for the first year. And then when he turned 1, we started interferon, and he's now transfusion independent. I saw him last weekend, and we had a big and rare anemia party, and his family. I mean, he's 2 years old and he's running around everywhere. And I just think how amazing, this is a child that used to be having to go for all these transfusions, and now he doesn't have to anymore. So, yeah.
Fantastic. And we also have one from Sally Thomas. If you'd like to unmute yourself to us.
Thank you. So this is a very obscure basic science question, but I'm hoping in the context of rare anemias, I'm still allowed to ask it. I'm intrigued by the category of patients with CDA1 with the C15 or 41 mutation.
Yeah.
To me, the ORF, the open reading frame bit of the gene name, suggests that this is an RNA encoding gene rather than something that's translated. And I'm just curious whether that is the case, that it's one of these functional RNAs that's influencing heterochromatin organization in this context.
That's a very interesting question. So we have actually now officially named it. So the open reading rate, so C15 or 41 means that it is the 41st open reading frame on chromosome 15. And so that those names of they basically just mean that we don't know what they code for. And some of them, you're right, don't code for anything, and they're RNAs. But this one is actually a protein, and we can detect it by Western blot. It interacts with codenine, so it's actually been renamed CDIN. So we've got codenine and CDIN, CDAN and CDIN. And this is an old slide that still has the C15 or 41 name. But interestingly, it probably is to do with RNA processing. So yes, you're right. It's not an RNA, it's not long coding RNA, but it probably is involved in processing of long coding RNAs.
Thank you. That sounds like an interesting paper for me to seek out.
Well, get in touch if you're interested, because we do research on this, and we were always interested in people who want to know more and get involved. Okay, so I'm going to move on to DBA, diamond blackfan anemia. So DBA is also about 1 in 100 to 200,000. This is a little girl there was a little article about her in the Mail Online because she was going for a bone marrow transplant, and I think they were doing some fundraising. And the features of DBA are, first of all, that they tend to present early. So they tend to present in the first year of life. And it used to be that if you didn't present in the first year of life and it looked like DBA, most pediatric hematologists would say it's not DBA. But this is really changing because we're doing genetic screening in a lot more individuals, and we're finding lots of interesting things, milder forms that present later. It's a macrocytic anemia with, again, a lower tick count. But these, they don't have so much, they can have fingers and toes abnormalities, but the abnormalities tend to be a lot more severe. So they can have cardiac abnormalities, and they can have cleft lip and cleft palate. And then, as I said, in the bone marrow, you don't see anything. So this is, again, quite an old data, 2011, but you can see the age at which the children presented. And you can see that they're really mostly presenting very early, and then a few bump later. But I think it'll be interesting if we sort of try and chart our data, maybe through the National Haemoglobinopathy Registry, to say, you know, are we getting people presenting older? And if you get involved, I'm quite involved with DBA UK, the main charity that looks after these patients. And whenever you go to their conference, you have families talking about DBA, and it's almost like a competition of who had the lowest hemoglobin. So you'll have some, and my child had a hemoglobin of 2.3, and then one was, my child had a hemoglobin of 1.7, and it's just, you know, like a mark of honor. But the really sad thing is that it takes such a long time to get the diagnosis, and almost invariably, the story is a mum that says something's not right about this baby. They go to the GP back and forth. Oh, you're just an anxious mom. Oh, it's just your first one. Oh, it's just your second one, and they're so different from the first. Blah blah blah. Then after weeks of or months of taking this baby, saying something's not right, the GP finally does a full blood count, they sent it off, and then the mum gets a phone call same day, you must come to A&E immediately. And then, of course, they get told it's probably leukemia. And then it's almost like a copy paste, these stories, right? So we really want to try and avoid having to have these traumatic experiences for the families. This is a bone marrow of somebody with DBA, and if you're used to looking at bone marrows, you will see, oh yes, there's a nice megakaryocyte, there's lots of myeloid cells, and look, I only see one erythroid cell, and it looks very odd because you're just looking for them and they're just not here. As I said, you can have these abnormalities. So, for example, a triphalangeal thumb, so 50% have an associated defect, 50% of which are craniofacial, so cleft lip, cleft palate, 38% are upper limb and hand, particularly thumbs, 39% genitourinary, and 30% cardiac abnormalities. And then the genetics, it's mutations in ribosomal protein genes. So it's dominant because if you've got mutations in both your alleles for your ribosomal protein genes, it's not compatible with life. So it's what we call haploinsufficiency. So you've got one abnormality on one side, and that means that you don't have enough to have a normal cell function. The commonest gene is RPS19, and then RPL5, and then these are all the names. You can see that there's some common ones, and then some very rare ones where there's only one or two patients or one or two families been described. And 50% of these are de novo. So like I explained, the parents are fine, but then the child got the mutation either through one of the mutations in one of the gametes or in utero, in the embryo itself. But here, where it's very different from CDA is that actually, once you start screening the parents, if you realize that one of the parents is a carrier, even if they're not anemic, they still carry a risk of malignancy. So having a mutation in a ribosomal protein gene increases your risk of solid tumors and huge increase in MDS and AML. And this risk is still there even if you're not anemic. In fact, so we've got a child that was diagnosed at birth with DBA, and then we tested the parents, realized the mother had the mutation. And then when you go back in the history, it turns out she was given a couple of transfusions because she got very anemic during pregnancy 2 pregnancies ago. And then you think, well, why would, that's not normal. Why didn't people start digging then? And I think just nobody thinks about it because they're just such rare conditions. For those who are interested in the genetics of it, it looks like, so we've got these ribosomal protein mutations, which then leads to abnormal ribosomal function, and then the abnormal ribosomes can't process RNAs correctly. And GATA1, I was talking about KLF1 being a transcription factor. GATA1 is an even more important transcription factor in red cells. And so it doesn't get processed normally. It triggers this P53 and apoptosis, and that's what leads to the maturation arrest. How do we treat these patients? First year of life, we give transfusions because the main treatment is steroids, and we wouldn't want to give steroids to a baby, certainly in the first year of life, because we want them to be able to grow. And also we don't chelate them because of damage to growth plates. So the first year of life, they're just transfused, ferritin goes up. Then when they're 1, you can start to chelate them, but also you give them a trial of steroids. You give the trial for 4 weeks, 80% of them respond, but of those, only half manage to have a sustained response at a low enough dose of steroids that you think it's safe to give long term. If they don't respond or they need too high a dose, then you go back to transfusions and then consider them for bone marrow transplant. A small proportion actually revert to normal without treatment, which is very weird. You can go from being transfusion dependent to transfusion independent with no treatment, and we don't know why it happens. If you look at the DBA registry, survival, I mean, this is quite old data, but survival was 77%. But actually, if you do the bone marrow transplant early, 9 years or younger, the survival was 93.8%. And they do unrelated donor transplants now, which have also had better survival than in the past. It's still a cause of early death. So CDA, we don't have any data about life expectancy. DBA, we know it has a reduced life expectancy. This is again registry data. So 36 deaths were reported to the registry, of which 70% were treatment related. So 5 died from infections, 5 died from complications of iron overload, 1 from cardiac tamponade, and 14 from stem cell transplant complications. And then 22% died because of a complication of the DBA itself. So 1 from severe plastic anemia and 7 from malignancy, and then the rest were unexplained. Now, the iron overload is quite different from the thalassemia iron overload, and this is for a same amount of transfusions. If you got a thalassemia and a DBA patient both receiving 3 units of blood every month, the DBA patient will iron overload worse than the thalassemia, and that's because it's back to that bone marrow being full or empty. In thalassemia, the bone marrow is full of developing erythroblasts, and all those erythroblasts are filled with transparent receptors on the surface. So when you get iron if you give a transfusion, lots of free iron gets released immediately with the transfusion because of the cells that lies immediately, the older cells. And all of that free iron in a thalassemia patient gets bound to the transferrin receptors inside the bone marrow erythroblasts. Whereas in a DBA, there's nothing in the bone marrow. So that free iron just goes straight into the liver and the heart. So here's my conclusion for DBA. Bone marrow is empty, it's dominant, the carriers are affected, i.e. they have a risk of cancer, and we do suggest screening for them. You can treat with steroids, transfusions, or BMT, and they do carry a risk of cancer. And then in the last couple of minutes, I'll just mention the way we test. So I mentioned the R92 panel, and we have a good practice paper on NGS in rare inherited anemias that came out last year. It's a joint BSH and EHA. It's not a guideline because there's not a lot of data, but good practice paper. And we start off with a blood test, and we end up with a report 12 weeks later, and you might think, well, why did it take 12 weeks? And you could look at this and go, oh yeah, there's a lot of steps between the blood sample and the report. But actually, it's just NHS staffing levels. So if we had enough staff, we could do it very easily within 3 weeks. And we could actually do it within a week if we were, organized and had good levels of staff. So the reason it takes 3 months is just staffing. But just to show you a little bit about what happens in between. So we take the blood sample, we extract the DNA, we quality control it and quantify it. So if you have a baby and you send a really tiny sample, we wouldn't waste your time going through the whole process to then say that it didn't work. So from the beginning, it would say, okay, we have enough DNA or not. Then we do this thing called barcoding and library preparation. Barcoding means that you label each sample with a tiny little 6 base pair barcode so that you can then pool. We can sequence 30 patients altogether, and that's what makes it cost effective. So and also it means that we can do 5 cases of inherited anemia panels, 5 cases of epilepsy panels, 5 cases of cardiac panels. We can sequence them all together because that barcoding and the library preparation means we can sequence them all in one way. Then after you've done the sequencing, which takes about 24 hours, and your quality control, you separate all your samples with the barcode. So you're only looking at one individual and you match it to the genes that you're expecting to see. And then you call the mutations. You say, what's different between this patient and the reference genome? Then you annotate it and filter it. So for example, if you see a mutation that is common in like 10% of the population, it can't be disease causing, otherwise 10% of the population would have this condition. So you just throw those away, you don't look at them. And then we do the really complex bit, which is the variant analysis, which I'm not going to discuss today, but that's the really interesting bit that the clinical scientists are doing in the lab. Then we discuss all of these variants in an MDT, and then we write the report. But even though we have such fantastic, complex, exciting, technology, at the end of the day, everything has to start with the patient. And what do I mean by that? We have to take a really good, thorough history, do a really good, thorough examination, and do all of our standard blood tests before we do all the exciting bits about genetic analysis. And that's partly because if you get a list of variants, but you don't know really the details of the phenotype, you won't be able to interpret them. So we can't write a report if we don't know what the patient's phenotype is. And out of all the panels, when we do the panels, we only make a diagnosis in 40% of cases. And in those, the majority confirms what was suspected clinically. In 10%, we have massive changes, either completely new diagnosis or we've got the wrong diagnosis from the phenotype. And that has profound implications in genetic counseling and change in treatment. But obviously, knowing the genetics also allows you to do genetic counseling. But also, I think that as we accumulate information, we'll be able to give patients in the future an idea, you have this mutation that responds to splenectomy, or you have that mutation that's much harder to chelate, so we'd be able to have a bit more information. And this is my next to the last slide, my take-home messages about CDA and DBA. They're very rare, but they're actually probably underdiagnosed. They're not completely scary, and there are people around who can help and advise. And this is really where it's helpful that we now have these networks. And patients really just want you to listen to them and seek specialist advice. So when you hear patient stories, yes, it's annoying for them that they know more than the hematologist about their condition. But what they don't want is someone who says, I don't know much about this condition, but you don't need such and such. It's just, they need people who say to them, I don't know much about this condition. I'm going to find out. And the thing about rare diseases as well is that you look in a textbook and we say, CDA doesn't include any gastric abnormalities, but that might be because we don't know yet. So in fact, at our CDA conference, we had 2 patients that spoke to each other and they had very, very similar symptoms. Now, maybe it's not related to their CDA, but maybe it is. So I think as doctors, we can't say, no, this is not part of your condition because we just don't know. So we have to be really open and listen to the patients. And sometimes seeking specialist advice involves going out of the country as well. We have good international links. This is my last slide to say, it's really important to work with the patient organizations. So Congenital Anemia Network is based in Oxford, but kind of will cover patients all over, and DBA UK is all over the UK. But, we can really work better by involving these charities because they're here to support patients and they want to do these partnerships with their clinical teams. Thank you very much. Any questions on DBA or anything else? Yeah.
So is there variation in the time frame of return of the panels? Because we find that it takes many months to get the panels.
So there should not be variation. When we discuss this, so we have, so the 4 GLHs meet every quarter with NHS England, and we have these discussions, and each of them usually says, yes, we're mostly on top of our turnaround time, but then I hear these things repeatedly, and it absolutely, I mean, okay, it should be 3 months. Maybe it will take 4 months, but if it goes beyond 4 months, that is not okay. And you need to get in touch with somebody, and it needs to be, and of course, it's not that it's not because they're sitting around having coffee, right? I mean, we all know this, but if there are issues and not being picked up, we really need to know about it. And one of the other problems, depends where you are, but for example, if you're east of England, then you can't send your sample directly to Manchester. It's not allowed. You have to send it to Cambridge, where they do the DNA extraction, and then they send it, okay? And then from Manchester's point of view, their 12-week turnaround time starts when it arrives in their lab. From your point of view, the 12-week turnaround time starts when you sent the sample.
It was like a tracking order.
Yes, and again, we've discussed with NHS England, and said, yeah, we're building this. I mean, you know, I already have gray hair, but I don't think there'll be any brown hair left by the time it's, and we've done an audit. There's been problems in London. So North London has to send to GOS before they send to King's. And again, I mean, they've been tracking it, and there's like samples that stay for 6 weeks in GOS before they go to King's. And it's not about naming names. You know, I'm not saying Oxford is better than anywhere else, but we have, you know, we haven't got a good system. We have to try and work out how to make things better. And if there is a recurrent problem, we do need to know about it so we can try and see what we can do. All right. Any other contentious or non-contentious questions?
Thank you very much. And this is a question more just about when we do the rare anemia panels and then what we do with the results we get them into better plans. So I've got a small cohort of patients with these refractory iron anemias where they have intravenous iron treatment, and one internets have got some mutation that says just of a refractory iron deficiency anemia. I don't know what is there any to the database of those patients?
No, so they should probably be included in the NHR, and I think we should probably think about making sure that we tell everybody that they should be included. I've got one. So are they definitely diagnosed with 2 mutations, 2 TMPRSS6 mutations, for example? 2 mutations or only 1? See, this is the thing, is I've got one who's heterozygous, and so there's a lot of these cases, and so there's someone called Mark Fleming, you probably know, in Boston. He's quite interested. So, I mean, so number one, we can try and work with people internationally if they've got genes that they haven't published yet, but then you send a few samples, and then if they find something, then it goes in the publication, and then it becomes a gene that's well known, and then we can start to include it on our panels. And also, I think, again, you know, if each one of us has 1 or 2 patients, maybe there's just something we don't know yet, and we've got to put them together. So, and I'm not a fan of setting up different databases. I won't go into the politics of DBA databases, otherwise we'll be here all day. But I think it's very important for the patients that we work all together to put all of our data together, because that's national data. Yeah, absolutely, on the national database. Yeah.
So we do have a few questions from our online attendees.
Yeah.
Claire, if you would like to go first, please.
Oh, thank you. Thanks, Noémi. That was fascinating. I have a couple of questions, if that's not too greasy. The first is with regard to cancer screening in DBA. So I've got a couple of younger patients with DBA, but one who's now early 30s, and we probably need to be thinking about colonoscopies, etc. And the younger patients have bone marrows and myeloid NGS blood films. But is there anywhere that I can find you know, the non-hematological malignancy cancer screening advice?
Yeah, so we've just published a sort of guidance. It's not really a guideline. It's not even a good practice paper, but there's a bit of guidance about DBA in adulthood, and you know, it's not massively evidence-based, but hopefully it's in blood. It's published in Blood a couple of months ago. So hopefully there's some guidance in there. But generally, and again, it also depends on what the patient's been told. So we were talking about this earlier, I can't remember with whom, about trust, right? So you might have a patient that went through the whole pediatric process and nobody's ever mentioned cancer to them. And then they appear in your adult clinic and you're like, right, you've got this massively increased risk of cancer. And then, you know, they feel like, who is this person that's telling me all this bad news I've never heard of before? So I find that when they come into the adult service, I have, and also the whole transition process where they used to have their transfusions on the pediatric ward and then suddenly they're in the DTU with all these old chemo patients, you know, that whole process is so traumatic that I don't tend to talk about cancer for the first couple of years until I feel like they really trust me. But absolutely. So, and again, so it depends who you speak to. Some people will say you need a yearly bone marrow, you know, every year, irrespective of what's happening to the counts. I don't do that. I do a yearly myeloid panel, and I try and convince them to have a bone marrow every 5 years, 3 to 5 years. Colonoscopies, absolutely. And then the other thing for women is breast cancer screening, which is really difficult because mammograms are not very sensitive for young people. So I haven't done it yet, but I'm planning to do an MRI. But yeah, that's essentially what we do. And then it's talking about, you know, skin, sunscreen, etc., and watching out for skin cancers. But it is very difficult. And again, I think we can try and work with the NHR a little bit more to so that we have data to back up to the patient, for the patients, I think.
Yeah, thank you. That's really helpful. And my second question was just about the proportion of patients in whom you don't find a typical genetic abnormality or a raised red cell ADA. I've just inherited one of Emma Aswood's patients who, you know, phenotypically very much has DBA, and he was steroid responsive from when he was diagnosed, age about 5, had about 4 years of steroids, but he's been steroid independent, not required transfusion since then. And there were none of the usual markers. He had his genetic screen repeated in 22, so he should have had the most up-to-date panel. Yeah. Do you see that quite commonly?
Yeah, I think we still do. And I think, again, it's really important that we all work together to, you know, and, you know, I don't do DBA research, and that's mostly done in London, but, you know, that we work with those teams so that if we can get whole genome sequencing or anything else, I absolutely would keep pushing for trying to find a genetic diagnosis. And it's a bit like CCR1 mutations, which is ADA2 diseases called like DBA-like instead of DBA. And there's been quite a few, since that gene's come out, there's been quite a few cases of quote unquote DBA that have been diagnosed with that. So I think it is worth, with these really rare diseases, really pushing for further genetic analysis.
Yeah, I think the benefit would be, you know, family screening, wouldn't it? Because your siblings have had a normal full blood count, but who knows if they might have an increased cancer predisposition.
Yeah, yeah, and also the risk of that individual passing it on. So if it really is DBA, then it'll be a 50-50 risk. And if you know the mutation, then you can do pre-implantation genetic diagnosis. If you don't know the mutation, you can't. But if it's one of these rarer recessive DBA-like syndromes, then suddenly it's much better because there is pretty much no risk they can pass it on unless there's consanguinity.
Yeah, yeah. Thank you.
Any other questions on the?
There's Emma Aswood's question.
I don't see them. Can you read them? Can you read it?
Got a hand up.
Oh, Emma.
Hi, thanks very much, Noémi. My question is, we're seeing more patients coming through from genetics or patients that have had a red cell panel due to a very mild anemia. So for the DBAs, it's easy to treat the transfusion dependent or the steroid responsive. But for these patients who aren't needing treatment and are picked up incidentally, we're obviously doing cardiac and renal scans. Should we be monitoring them exactly the same way? So the, you know, bone marrows regularly, MGS panels regularly? I feel these are conflicted with what I should be doing with these.
So these are, say that again, why were they screened for mild anemia?
So sometimes we've got mild anemias and they get a genetic panel that shows an RPS mutation, and some have come through genetics where they've incidentally been found to have an RPS mutation either on the 100,000 genome or for some other genetic reason. and then transferred into my clinic from the geneticist.
So,
Some of them aren't even anemic.
okay, so if it's definitely, if it's a definite pathogenic mutation, yeah, yes, absolutely. They need to be followed up and they need to have, I mean, I would definitely wouldn't do a yearly bone marrow on them, but I would definitely do a yearly, I would definitely do a bone marrow, because the other thing is that they want to look for the myeloid maturation, and they look for fibrosis. So I would do one bone marrow, I would do yearly myeloid panels, and I would do cancer screening for all of them as though they were, you know, a sibling or a parent of somebody with overt DBA. However, I just want to make sure that we're talking about definite pathogenic mutations, not variants of uncertain significance. Because if it's a variant of uncertain significance,
yes,
then they should not be, then they should be discharged. They should not be followed up.
okay. And then the ones with the pathogenic genetic, then they should follow that route. Yep, that's perfect.
Yeah.
Thank you.
Okay, and then I think also, so for some of them, what you might find, I mean, obviously you look after children, so you won't find it, hopefully, but once they get to adulthood, that they may get problems when they get, you know, for pregnancy, and then they may need transfusions through pregnancy. So it is worth keeping them in hematology. All right.
Thank you.
Naomi.
Thank you.
Thank you.